The following podcast is part of a certified educational activity titled RiskReady, a systems approach to improving the recognition and treatment of high-risk, HR-positive, HER2-negative early breast cancer. Access the entire activity and complete the post-test at peerview.com/BWD860. Downloadable slides and practice aids are also available.
Welcome to this continuing education event. Today, I am Karen Daly. I'm a professor in the Division of Hematology and Oncology and a breast medical oncologist at University of Florida in Gainesville, Florida. And today we'll be sharing information about a project called RiskReady, which is a systems approach to improving the recognition and treatment of high-risk HR-positive, HER2-negative early breast cancer, which was a quality improvement initiative undertaken at University of Florida. Some of the goals of today's time together would include, first, recognizing the high risk of recurrence of HR-positive, HER2-negative early breast cancer patients who are high risk and the benefit of adjuvant CDK4/6 inhibitors in reducing that risk of recurrence in this population. And secondly, sharing a quality improvement initiative, which may be useful for other institutions, which included two major components. One was improved identification of patients who are candidates for adjuvant CDK4/6 inhibitors. And secondly, attention to side effect and adverse event monitoring to improve adherence and persistence to treatment. So there are many gaps and opportunities for improvement in this patient population, high-risk HR-positive, HER2-negative early breast cancer, which led to the development of this project. And I'm going to share with you today some of the current evidence and standards of care. So first, some real-world data about our understanding of the risk of recurrence in node-positive, HR-positive, HER2-negative early breast cancer. About 30% of patients in this group who've received standard endocrine therapy go on to experience disease recurrence within 5 years of their diagnosis, and this is a group that would then benefit from treatment intensification. A real-world study utilizing data from the Flatiron database demonstrated that an increased risk of recurrence is seen in a population similar to those who participated in an adjuvant CDK4/6 trial, Monarch, on the cohort 1, and we'll be discussing that population in more detail throughout today's session. So here's some more data to help describe and understand the risk of recurrence that these patients are facing. Again, this population we're talking about today are node-positive, HR-positive, HER2-negative early breast cancer. And you can see here the invasive disease-free survival when we look by nodal status, with increased number of nodes being associated with a higher risk. Patients who were in the Monarch cohort 1 had a greater than threefold risk of recurrence compared to those without these features. So these will be some of the patients we're discussing today. In all subgroups across N1, N2, and N3 status, these patients are at high risk of recurrence. And you can see among the subset with N1 disease, or 1 to 3 lymph nodes positive, that those who had high-risk features similar to those eligible for adjuvant abemaciclib, as in the Monarch trial, had a more than doubling, a 2.2-fold increased recurrence risk, which translates into a 15% difference in absolute risk of recurrence at 5 years between these two N1 subgroups. So how do we assess the risk of recurrence in HR-positive, HER2-negative early breast cancer? There are both clinicopathological features that we can consider, as well as tumor biology. And increasingly in clinical practice, we are integrating both the clinical, genomic, and additional identified risk factors that would allow us to have a best estimate of a patient's risk of recurrence so that we can provide escalations in treatment where appropriate. So some of the clinical pathologic features that we would consider would be the anatomic stage, the tumor's histologic grade and size, and nodal status, both of which are important contributions to the anatomic stage, as well as genomic assay results, commonly those used to determine the role of adjuvant chemotherapy. Ki-67 is also a prognostic biomarker. While not required to guide adjuvant therapy, it is sometimes useful and will come up throughout our conversation today in terms of identifying patients. Some of the other relevant factors unique to a patient would be their age and menopausal status and other comorbidities that they suffer. So here we are looking at patient identification for candidacy for adjuvant CDK4/6 inhibitors, patients who were eligible for monarch-E, which was abemaciclib adjuvant, and NATALEE trial, which was adjuvant ribociclib. In monarch-E, you see in cohort 1 patients with N2 or N3 disease, so 4 or more positive axillary lymph nodes were eligible, and select patients with N1 or 1 to 3 positive axillary lymph nodes were eligible, specifically those who had a T3 tumor size, equal to or greater than 5 centimeters, or histologic grade 3. Cohort 2 included additional patients who had N1 disease and a centrally confirmed Ki-67 20% or greater. In the NATALEE trial, there were some additional patients who were eligible earlier in anatomic stage, including those who had T2 and 0 disease or stage 2A, if they had Ki-67 20% or more, a high-risk genomic assay such as Oncotype DX, Prosigna, or PAM50, or MammaPrint, or EndoPredict. So this had a larger patient population by anatomic stage. And so these are some of the criteria that have been used to identify patients who would benefit from adjuvant CDK4/6 inhibitors. Recent data has shown how important adjuvant CDK4/6 inhibitors are for this patient population compared to standard endocrine therapy alone, and improved not only invasive disease-free and distant recurrence-free survival has been seen, but also improved overall survival. monarch-E's landmark 7-year analysis has shown an improvement in overall survival, which is demonstrated here. At 6.3 years of median follow-up, the addition of abemaciclib to endocrine therapy reduced the risk of death by 15.8% versus endocrine therapy alone. Although the overall survival data for NATALEE is not as mature, at a recent 5-year update for adjuvant ribociclib, a persistent invasive disease-free benefit was seen compared to aromatase inhibitor and endocrine therapy alone, with a hazard ratio of 0.716 and a persistent benefit across all subgroups included. And that includes the N0 or node negative patients that were included on the NATALEE trial, but not on monarch-E. So we've learned that this is very important therapy, adjuvant CDK4/6 inhibitors for our high-risk hormone receptor positive, HER2 negative early breast cancer patients. But the question is, are we delivering this to them practically in the clinic? And despite this known benefit and now established proven benefit even for overall survival, there appears to be an opportunity for improvement. Data that's shared here is from some retrospective real-world data based on the Flatiron database, and includes adjuvant abemaciclib use. And here you see that as many as 60% of eligible patients may be missing the opportunity to receive this therapy. In looking at which patients these are, there seems to be an association, at least in this data set, that patients who were 65 years of age or older did not receive abemaciclib. In terms of the racial and ethnic breakdowns of patients who did not receive abemaciclib. Hispanic and Latino patients had an increased rate of not being prescribed or utilizing abemaciclib. And also some of the factors that did not impact abemaciclib utilization were the patient's insurance type, socioeconomic index status, and the practice setting in which they were treated, whether it was academic or community-based. So clearly this shows us that there's an opportunity for improvement, and this is part of the impetus for the quality improvement project that I'll be sharing with you today. Here's data on the two adjuvant CDK4/6 inhibitors used in high-risk early breast cancer in terms of some differences between their side effect profiles and adverse events. Here you see higher rates of diarrhea with abemaciclib than with ribociclib, and higher rates of neutropenia with ribociclib than abemaciclib. Both of these agents can cause transaminitis or elevated ALT and AST. There is a risk of thromboembolic events associated with abemaciclib and a risk of QTc prolongation with ribociclib. In terms of dosing, abemaciclib is continuously dosed twice daily. Ribociclib has a 3-week on, 1-week off schedule. And the starting doses in the adjuvant setting and dose reductions are listed here. And I'll bring your attention to ribociclib starting dose in the adjuvant setting, which is different than the metastatic dosing, which is 600 milligrams a day. Here in the adjuvant setting, the starting dose is 400 milligrams daily. In terms of follow-up for patients who are starting these therapies, there are some recommendations about the optimal schedule and follow-up to assess either lab abnormalities or adverse events that the patient's experiencing. In the first 1 to 2 months, patients should be monitored every 2 weeks with a CBC with differential, electrolytes, liver function test, creatinine, and assessment of their side effect experience between months 2 to 4. Monitoring of the same can be every month. And beyond the 4th month, monitoring can be as infrequently as every 2 months. So an additional component of our QI project was to ask if there would be a benefit to patients in terms of more frequent initial monitoring when many of the side effects occur, and how this might be practically implemented in real-world practice. We'll be sharing that with you later in this session. One of the things that has been helpful and useful in terms of maintaining adherence and persistence to these therapies has been a low threshold for clinicians to dose reduce to assist patients with staying on therapy and maintaining a good quality of life. And here you see data both from Monarch E abemaciclib as well as NATALEE trial, which had similar data, that dose reductions were not associated with reduced efficacy, although dose reductions were associated with patients persisting on therapy. Here we're sharing some information about oral therapies and factors that may influence a patient's adherence and persistence to oral treatments. It's a multi-dimensional phenomenon, adherence and non-adherence. Some of those features are patient-related in terms of the patient's understanding and perception of the benefit of the therapy, issues with forgetting or building a routine around adhering to their treatment, and mood disorders such as depression or anxiety, which may contribute and increase the risk of non-adherence or non-persistence. Adverse events, which we've talked about a little bit, therapy-related risk factor that can lead patients to discontinue or not have optimal adherence, and the pill burden, which in patients both from this treatment and from their overall pill burden or polypharmacy can contribute to non-adherence. There are some additional factors such as comorbidities that may contribute, and some that are healthcare system related. The duration of follow-up visits, prescribing errors on clinicians' parts, and the relationship that the patient has with their healthcare team, and agency in terms of their own healthcare decision-making can all play a role in adherence. There are also some social and economic features which have been associated with higher risks of non-adherence, patients at the extremes of age, the youngest and oldest patients, patients who have a higher out-of-pocket cost for their medications, patients with lower income and education levels, and unmarried patients have historically suffered less optimal adherence and persistence. So there are a variety of ways in which we can address some of these. Those can include continuous monitoring and reassessment during treatment, attention to adverse events and interventions to reduce adverse events that patients are experiencing, including dose reductions, as we've mentioned, which don't appear in this setting of adjuvant CDK4/6 inhibitors to compromise efficacy, providing clear instructions and education to patients, and involving a team that includes specialty pharmacy services, and also, as you see under patient-related interventions, may include a team including psychological assessment or support for patients who are suffering mood disorders, and nurses who are, a critical part of the team and provide patient education. So in terms of addressing some of these gaps and clinical challenges, we have discussed today so far that we recognize there's a high risk of recurrence that remain for patients facing HR-positive, HER2-negative early breast cancer, and this has prompted an intensification of therapy with adjuvant CDK4/6 inhibitors. This is now a new standard of care, which has been established to reduce the risk not only of recurrence, but even death and improve overall survival outcomes. Yet there's a suboptimal uptake of these therapies in real-world clinical practice. So we're seeking to understand some of the practice dynamics that may limit patients' access to this therapy and adherence to this therapy. And in the final point here, we've paid some special attention that we'll discuss in terms of optimal follow-up for patients that will allow them to adhere and persist to treatment, which is potentially life-saving. This is among some of the rationale that led to our QI project. And so shifting gears to discuss the project at University of Florida, which was twofold, really, improving identification of patients with high-risk HR-positive, HER2-negative early breast cancer, but also improving adherence and persistence to therapy. To give some background on the setting, University of Florida is one of the nation's top public universities and has a large presence in the southeastern United States with over 5 million outpatient visits and more than 120,000 inpatient hospital admissions annually. So we utilized a common quality improvement technique, which is the Plan, Do, Study, Act cycle. In planning, we've identified an area for improvement and defined clear objectives and outcome measures. We then moved on to doing and implementing this intervention on a small scale at a single institution, documenting observations and collecting the data and noting some challenges along the way. After this, we studied and analyzed the data to see how it compared to what we expected and predictions that we had, assessed what worked, what didn't, and why, with feedback, and then moved on to acting, which is based on this analysis, refining and implementing, and hope that what we share might be useful for other institutions. So here is a bit about our quality improvement approach at the University of Florida. We identified a steering committee and a leadership group that was charged with directing the clinical and operational focus of this project, and then had some on-site training for some of the clinical providers who championed the launch. That included nurses in the clinic and in both the infusion suite and also in the clinical practice where patients have visits. We provided an overview of our QI initiative to them and engaged nurse navigators as well as champions, as well as our colleagues in IT. We had a regular meeting schedule so that the group could engage and share lessons learned and some of the implementation challenges, and then formulated and took action on this, and always interacted to get feedback about what was working, what wasn't working, and changed our process along the way. So some of the practice gaps that have been identified in HR-positive, HER2-negative early breast cancer, specifically at the University of Florida as part of this project, we recognized that we didn't have a system to ensure identification of HR-positive, HER2-negative early breast cancer patients who would be eligible for adjuvant therapy with a CDK4/6 inhibitor. And this was in part because there was some challenges with the electronic health record and documentation, where there was a limited ability to collect and organize and report the data based on patient tumor characteristics and risk stratification. We also realized that there was a potentially suboptimal use of this evidence-based guideline, adjuvant CDK4/6 inhibitors, in our patients who should be receiving this therapy. And part of this, again, was related to some of the challenges surrounding the electronic health record and documentation, where there was not the capacity to extract and analyze information about the treatment selection for patients with high-risk HR-positive, HER2-negative early breast cancer. And we also realized that there might be suboptimal monitoring for our patients who have been offered adjuvant CDK4/6 inhibitors, and missed opportunities to rapidly detect and mitigate adverse events in real time that could contribute to improved adherence and persistence. And in response to this, we changed some of the workflow, or realized that some of the issues would relate to workflow, that the process for monitoring and following up patients could potentially be improved from the current standard practice. So some of the proposed QI interventions with our project in terms of both opportunities for improvement and the root causes. A cancer registry was among the most impactful proposed interventions, which was not established at the beginning of this project, but would allow for identification of all the relevant patient and tumor characteristics needed to identify patients who are candidates for adjuvant CDK4/6 inhibitors. This cancer registry could potentially also allow documentation, tracking, and reporting of treatment selection and delivery for high-risk HR-positive, HER2-negative early breast cancer patients. And more in speaking to the adherence and persistence piece, we also, I proposed a protocol for patients whereby they would receive a follow-up phone call at 1 week after treatment initiation by a member of the healthcare team to assess their adverse event experience, to provide education, and to determine if they required or warranted more clinical follow-up to address any problems they were encountering in that first week on therapy. Some of the methods that we used to achieve these interventions were a cancer staging form, which is available in the EPIC EHR and allows for entry of clinical characteristics. We developed an EPIC smart phrase to prompt an adherence follow-up phone call at 1 week after initiation. And we developed a patient registry that allowed for follow-up of patients in terms of their pharmacy fills and adherence and persistence to therapy. So developing a cancer registry was part of the solution that was found to meet the needs of identifying patients who are eligible for adjuvant CDK4/6 inhibitors. How we worked to do this included development of a structured data entry process, working through some of the issues with data extraction and reporting, ensuring that the data was both consistent and quality controlled. And this involved flexibility and collaboration across multiple members of our team. We did utilize REDCap and we migrated the data from the EPIC EHR. Some of the reasons why we determined REDCap would be the best approach are listed here. It's highly structured, it's customizable, it's easy, it has immediate analysis, and it's a very flexible and detailed database that could be utilized here. So what were some of the challenges and some of the barriers that we encountered as we worked to develop a cancer registry? One of the first was that in the EHR EPIC, we did not have accessible pathology data. This was because some of the important information, such as the ER status and the HER2 status, was stored in non-discrete formats or PDF-like bricks that was inaccessible for automated data tools to pull that out and extract it in an automated fashion. Thus, manual extraction was required, which is labor intensive. And at the time that we started our project, one of the barriers was that there was not a workflow for real-time staging entry, although cancer staging was ultimately became part of the patient's chart. This didn't always happen for 6 to 9 months, sometimes after initial diagnosis. So there was a window of time opportunity that could be improved. We worked to develop a cancer registry through utilizing our nurse navigators who are already part of the team. They did not currently have access to this at the beginning of our project, so we work with colleagues in IT to allow them to be empowered and have training and access to input in a format that you see here on this slide, information about the patient's diagnosis as it was already being discussed at a weekly tumor board meeting. So the workflow became that our nurse navigators would enter this information as was discussed in the tumor board meetings based on imaging and pathology results. And these were then signed off and confirmed and double checked by a breast surgery nurse practitioner or physician assistant. And that was a second checkpoint for validation. And then this was integrated with REDCap. Once the staging data was entered, it could be exported from there, which was novel compared to the prior system where it could not be exported. The impact that this has had is likely one far beyond this particular project in that it has allowed for real-time entry of data, including staging and marker status, to allow University of Florida to accurately identify eligible patients for this treatment and potentially for other treatments to come in the future. So sharing our results to date with data as of September 2025, it was March 2024 when we first implemented this project for nurse navigators to input the staging data. And at that time point, there were since that time point, I should say, there were 423 patients who've had staging entered. When we limit that to HR positive early breast cancer, the number is 360. When we further refine this to HR positive HER2 negative, 240. And when we get closer to the patient population that would be eligible for adjuvant CDK4/6 inhibitors, HR positive HER2 negative early breast cancer patients who are node positive, we have identified 38 patients from March 2024 through September 2025. This slide shows a nice part of our story where you see over time since beginning utilization of this data entry system and database formation from June 2024 to September 2025, a steady increase in patients with HR positive, HER2 negative, node positive early breast cancer who can be identified. This is a slide that provides some information as to the patient population and some of the qualitative measures that describe the patient population that we're discussing here. So you see in terms of age, we gathered data with most patients being in their 60s, but a wide variability from less than 40 to more than 80 years of age. You see an insurance breakdown here where we have included patients' payers and also the racial and ethnic breakdowns of the patients that we serve and who are involved in this study, with 68% Caucasian and 21% of patients identifying as African American. This also shows patient characteristics in terms of their tumor and how they were eligible by both T size, by nodal status breakdown, grade, and Ki-67. And we also collected data about patients who have or do not have a next visit scheduled in the upcoming 3 months, with, again, attention to adherence, and had 95% of patients who had upcoming appointments already scheduled. Here's further characteristics of the 29 patients identified as being eligible for adjuvant abemaciclib. Here you see a breakdown again by age, race, ethnicity, and insurance type, and time from diagnosis, and how many patients had a next visit scheduled. I would like to bring your attention to the abemaciclib usage area. Here you see that at this time point, 72% of patients had not yet initiated adjuvant abemaciclib who we found to be eligible, and 28% had. And we also were able to look further at possible reasons that this was, with more than 70% of patients not yet reaching the time point in their treatment through chemotherapy, radiation therapy, and multidisciplinary care where abemaciclib would be initiated. So this helped us to identify patients before they would reach the time point in their journey to be offered adjuvant CDK4/6 treatment. Moving on to the adherence and persistence part of our work, where we're monitoring adverse events, we initiated a smart phrase, which is a tool in the Epic electronic health record system that patients can insert into templates. The one that was developed here was utilized by LPNs in the clinic in the context of this QI initiative, and gave a scripted prompt which allowed LPNs to ask patients about the side effects they were experiencing, if they had access to supportive care medications, and to do this in a systematic, standardized format with a 1-week phone call initiated after their start date for adjuvant abemaciclib. The call script included, as I mentioned, adverse events that the patient was experiencing, including diarrhea and fatigue. It reinforced education on ways that they could reach their healthcare team and report symptoms, and additionally symptom management strategies. It also asked about their supportive care medications, and it was then generated messaging to clinic RNs who could view this and screen patients who might need an earlier clinic visit with an ARNP, PA, or physician to manage their side effects, or early dose reduction or dose hold. There is an additional piece to our adherence and persistence work, which was a collaborative effort with some of our specialty pharmacists. And in this part, we were able to track fills and refills and dose modifications for patients who initiated adjuvant abemaciclib, and integrate this data into our registry and dashboard to allow a better understanding and monitoring of adherence and persistence. We did find one barrier or significant limitation that we encountered during the project, which is that the Epic EMR was only able to track retail pharmacy data via SureScripts. So patients who were filling and receiving their medication through third parties that include patient assistance programs and alternative pharmacies were not visible. So some manual data collection and coordination was required in these patients. In further discussion of the monitoring and adherence part of our QI project, we utilized dashboards to create information where we could see patients longitudinally in terms of their treatment adherence and dose holds or dose reductions. And we also developed an additional smart phrase that could be used for patients who never started or never filled an initial abemaciclib prescription. These patients would not have been caught through the adherence and persistence mechanism. So this allowed us to ensure that we're capturing patients who were recommended or offered therapy, but that there was a gap in the initiation of treatment. And so in terms of our results to date with adverse events monitoring, most patients did not miss doses and adhered well to therapy. Dose reductions were common. Patient satisfaction, which was captured as part of the SMART phrase, was monitored, and RNs were flagged when any dissatisfaction with their adverse event experience was encountered. Real-time follow-up calls, again, were scheduled at 1 week after initiation. And the SMART phrase usage allowed for standardization of documentation and patient phone calls. So in summary of our project and its achievements to date, we've been able to establish a comprehensive cancer registry using REDCap to identify and track HR-positive, HER2-negative early breast cancer patients at high risk of recurrence. This enabled real-time staging entry into EPIC by trained nurse navigators and improved the speed and accuracy of patient identification. And this built and refined a live data dashboard where we were able to track other patient characteristics, including demographics, treatment plans, their medication adherence, and discontinuation rates. Additionally, we launched an EPIC Smart Phrase tool to trigger LPN phone calls at 1 week after adjuvant CDK4/6 inhibitor initiation to monitor early adverse events and adherence. We improved medication adherence tracking by working with our pharmacy colleagues to identify fill and refill data and document reasons for dose modifications and discontinuation. And we've confirmed that this project is both sustainable and scalable with workflows that fit into the current clinic model and that could potentially benefit other sites besides the UF healthcare system. Some of the key takeaways and recommendations that we would like to share from this QI initiative would include for individual practices to consider how your institution is identifying and monitoring patients with HR-positive, HER2-negative early breast cancer, if there might be the potential that some of these high-risk patients are being missed and not offered this life-saving therapy, and if a registry might be developed that improved identification and tracking of patients, as was done at University of Florida. The challenges that have been experienced in developing our registry hopefully would be instructive and helpful to other institutions who would wish to do the same for their patient population. And also we would suggest another opportunity for improvement would be a protocol similar to the SMART phrase one that we've utilized to increase the monitoring frequency of adverse events and ensure that toxicities are promptly identified and addressed to improve patient quality of life and experience and likelihood of adhering and persisting to adjuvant CDK4/6 inhibitor therapy. Thank you very much for your time and for your attention. I hope that this has been a helpful presentation.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by the University of Florida College of Medicine. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/BWD 860.